Hello, and welcome again to the Surgical Oncology Clinics podcast. Surgical Oncology Clinics is a quarterly publication from Elsevier consisting of review articles centered on a major topic important to surgical oncologists. The series has published for 32 years, and for our 8th podcast, we will be discussing the January 2023 issue devoted to clinical trials in surgical oncology. I'm John Vasallo, managing editor of the series here at Elsevier, and during this podcast, we will discuss 4 articles from the issue. Leading this discussion will be our consulting editor, Dr. Tim Pollack, professor and chair of the Department of Surgery at The Ohio State University Wexner Medical Center in Columbus, Ohio. Joining him will be the guest editors of the clinical trials issue, Dr. Syed Ahmad, professor of surgery and the Hayden Family Endowed Chair for Cancer Research at the University of Cincinnati College of Medicine in Cincinnati, Ohio, and Dr. Shishir Maithal, professor of surgery and scientific director of the Emory Liver and Pancreas Center at Emory University in Atlanta, Georgia. Welcome to all three of you, and over to you, Dr. Pollack.
John, thank you so much. I'm really excited about having the opportunity to chat today with Dr. Ahmad and Dr. Maithal, who were the guest editors for one of our recent volumes, Surgical Oncology Clinics. These two individuals are outstanding surgeons and leaders in surgical oncology, and they're also people who are actively involved with clinical trials in the field of surgical oncology. So we're incredibly lucky that they're with us today, and that they were able to put together such a wonderful volume from Surgical Oncology Clinic. So welcome, Syed. Welcome, Shishir. So excited to talk about these 4 articles. You know, the entire volume was really outstanding. And so I thought maybe we'd kick off focusing on the article from Dr. Schneider and Dr. Katz that looks at fundamentals of conducting cooperative group trials through the National Clinical Trials Network. You know, obviously randomized clinical trials generate the highest level of evidence to inform standard of care treatment guidelines for patients with cancer. We also know that it can be challenging to conduct clinical trials and that there's many different mechanisms to do that, but it does require an infrastructure and it does require some level of expertise. So I thought the article from Dr. Schneider and Dr. Katz did a very nice job highlighting how surgeons and other healthcare professionals can get involved with clinical trial work through cooperative groups such as the National Clinical Trials Network. So Dr. Ahmad, I was wondering, you know, you're obviously very involved nationally in several different clinical trials networks. And I was wondering if you could shine some light on this article from Dr. Schneider and Dr. Katz about the role of cooperative groups in doing the important work of randomized trials to answer important questions in the field of oncology.
Thank you, Tim. This was an important study for many reasons. And first and foremost was the fact that it really highlights how the NCTN works. That's the National Cancer Treatment Network. You know, the concept of the NCTN really began in the 1950s when the government really formed the Cancer Chemotherapy National Service Center. And there was a regulatory oversight mechanisms of conducting clinical trials. And the reason this concept really came about was because in order to conduct certain trials, you need a certain critical threshold of number of people enrolled on trials. And, you know, and many people try to do trials individually at academic centers and can't accrue enough patients. So the concept was really based on working together as a team in order to enroll patients to answer important questions regarding novel therapies and benefit to patients. And the very first cooperative group that formed was the CALGB, which is the Cancer and Leukemia Group B. And subsequently, multiple other cooperative groups formed in the preceding decades. Things were kind of reworked in the 2000s, specifically around 2010, when the government really looked at the NCTN network and really streamlined it. And now there's about 5 cooperative groups. There's the Alliance, the COG, which is the Children's Oncology Group, the ECOG, Eastern Cooperative Oncology Group, NRG, and SWOG, which is the cooperative group that I'm a member of. And each cooperative group have hundreds of institutions that form membership. Each group has regulatory center, disease groups, and support mechanisms like biorepository statistical centers, and they work together. And so when a study's open, like as an example, in the SWOG cooperative group, all the SWOG centers open the study. So it allows us to open studies and enroll patients onto studies very quickly, achieving the critical threshold. Now, sometimes even opening a study in the cooperative group is not enough to answer the question. We need even a larger sample size. So all the cooperative groups get together to open the same study, and that's called an intergroup study. So when one study is opened by multiple cooperative groups, it's called an intergroup study. And Dr. Snyder and Dr. Katz did a great job of outlining how a trial progresses through the NCTN. So the concept of a trial is formed by an individual who takes it to a disease committee in the cooperative group. The concept is vetted and the trial is designed in the disease group. And then once it's formed and finalized, it goes to the larger administrative oversight of the cooperative group. And then once it passes that, it goes to the national oversight, which is what we call the task force, and eventually to the NCTN steering committee. And once it passes the NCTN steering committee, then it's opened for trial accrual. And, that complex sequence of events was explained very nicely by Dr. Snyder and Dr. Katz. And I think he concisely and very clearly highlighted how trials are conceived and how it progresses through the NCTN network until it forms and opens. And I think, surgeons in the last decade have been very important in terms of being involved in cooperative groups, opening studies, designing studies. It also outlines very nicely the benefits of being involved in a cooperative group, benefits such as getting mentorship from senior faculty around the country, having exposure to thought leaders, being exposed to a multidisciplinary group, medical oncologists, surgeons, radiation oncologists, basic scientists. Running, as you mentioned, Dr. Pollack, running cooperative clinical trials are very expensive, and it provides an infrastructure to open studies and the regulatory oversight regarding quality control, data monitoring, safety monitoring. And so, there's a lot of advantages in terms of being involved in a cooperative group and opening trials through a cooperative group. And the study highlighted the advantages very nicely.
Yeah, thank you so much for that great oversight of the article. Maybe just a couple follow-up questions. For our listenership, I wonder if you could just give, folks some idea about the, approval process. You kind of very nicely outlined it. But for folks who aren't familiar with the process, maybe give us just some sense of like the timeline of when someone may have a research question to when the concept is maybe approved and a patient, is actually accrued to a trial, to give someone an idea of like the arc of what this looks like.
That's an important question, and it can vary. I've been involved in multiple national studies. The very first study that I did was actually cooperation with Dr. Katz, who wrote this article, and that was the Alliance 0211 study looking at management of patients with borderline resectable cancer. That trial, from concept to when we enrolled the first patient, was multiple years. It went through a vetting process, revisions in the concept, eventually went through the task force and the steering committee to open up. I've also been involved in, other trials that went through very quickly, like the SWOG 1505. From concept to enrollment was 1 year. So it really varies on many factors. One of the factors is whether there's a space in a question that it needs to be filled. If there are multiple competing trials on the national level, sometimes it takes longer to get your concept opened and patients accrued. If you have a question or a trial that's novel, there's no competing trials on the national landscape, then it usually moves through that timeline much quicker.
That's great. And then one other question I had for you, Dr. Ahmad, and perhaps I'd like Dr. Maitel also to weigh in on this. If I'm a surgeon at an academic medical center or in a community setting, and I want to get involved more with clinical trials, sometimes it can be a little bit daunting, right? There's SWOG, there's Alliance, there's ECOG. How can I get involved? Which one of these associations might I think about joining? And then what does it look like for, quote unquote, the average surgeon to get involved? And Dr. Maitel, I know you have a couple clinical trials open now, and maybe you can just highlight the different roles that surgeons can have, from being involved with the conception of a trial and being a PI of a trial, but then also accruing patients to trials, because we know it's super important that we have robust accrual. So how can we get more engagement from the surgical community?
It's actually not as hard as people think it is. So one of the very nice things that's happened in the last 10 years that surgeons have gotten involved in studies, and they've developed an infrastructure that makes it easier for newer surgeons to get involved and join. So most cooperative groups now have a surgical committee, and that would be a nice entry point for a junior surgeon who wants to establish a career identity in doing clinical trials, getting involved in the surgical committee. And then every cooperative group have disease committees. So gastrointestinal committee, melanoma committee, thoracic oncology committee. And through the surgical committee, they can then get involved in the disease committee and be exposed to, again, thought leaders. And over a period of time, there'll be opportunities to be involved as a surgical PI of a study. These cooperative groups also have lots of training courses to learn how to conduct trials, opportunities to apply for training grants, and even pilot grants that will allow you to build into concepts translational questions. One of the first things I would recommend is not being afraid to reaching out to someone who's involved in trials and asking them for advice and asking them to be a mentor. And Shisher, a great example of being a mentor on the national level and helping newer surgeons get involved in trials.
That's great. Well, thank you so much. I think that's super important for surgeons to understand all the different ways that they can get involved with clinical trials. So now that we've talked a little bit about some of the network and how to do clinical trials, I thought we could pivot and start to look at some actual clinical trials that were done for certain diseases that many of us treat. So Dr. Maitel, I wanted to start off with you and talk about the paper by Dr. Lee, Dr. Roca, and Dr. Mayo around biliary tract malignancies. And, I think this is particularly interesting because, biliary tract malignancies are relatively rare. So I think it speaks to the challenges in doing clinical trials in diseases that are relatively uncommon. And then also biliary tract malignancies represents kind of a potpourri, if you will, of different diseases: intrahepatic, perihilar, distal cholangio, gallbladder cancer. So I thought to start off with, maybe you could just comment a little bit on some of the challenges in studying a disease like biliary tract cancer.
Yeah, actually, the article did a fantastic job of summarizing the landscape for biliary tumors. And the first thing, again, with any rare cancer, it's very difficult to study and very difficult to enroll patients, because the reality is a very small minority of patients with that cancer diagnosis are actually eligible for clinical trials and actually participate. So anytime you're trying to do trials on a rare disease, it's difficult. And then, as you mentioned and alluded to, we have 4 different biliary tract cancers, and each of these are really distinct biologic entities. Although their chemotherapy treatments may be the same, but when you look and dive into their genetic makeup, the actual genetic mutations are different. The targetable mutations are different. The drugs that we would use to target these mutations are different. And the operations by which we treat them as surgeons are all actually very different as well. So there's this concept of lumpers and splitters. And given the rarity of this tumor, and particularly the rarity of each site of tumor, when dealing with clinical trials, oftentimes they get lumped together. And that's always the balance of clinical trials when we talk about the feasibility of the study and the ideal trial. And the best trial somewhere is in the middle road, and balancing between feasibility and ideal. And so the study very nicely focuses on the trials that have been done. And I think also, just as a general concept, as a surgeon, when we're focusing on either preoperative trials, postoperative or adjuvant trials, or even trials on locally advanced disease, we often extrapolate from what we learn from trials that are done in the metastatic or advanced disease space. And that's just, unfortunately, where the majority of patients are. They have metastatic or advanced disease, particularly for biliary cancers and pancreas cancers. And the majority of the trials get started there. A lot of the advancements get started there. New drugs are tested in that space, as well as, molecular targeted therapies are tested in that space. So we have to understand that space and work with our medical oncology colleagues, and then take what we learn from that area and start bringing it into the adjuvant, neoadjuvant, and locally advanced space. So I think the article very nicely details that and covers the advances that have happened in the adjuvant therapy, what we're trying to do now in neoadjuvant therapy, which is relatively a new landscape. And then furthermore, biliary tract cancers are a very interesting and very exciting in the sense that they are ripe with actionable targetable mutations. And there have been multiple trials in the advanced disease space looking at using medicines that can basically target specific mutations. And then we're trying to see how we can bring those into the localized disease space as well.
Yeah, thank you so much. I think one of the strong points of this article is that it does highlight a number of different trials that have been done in the biliary tract cancer space. As surgeons in particular, it's important for us to understand who may or may not need to be referred for adjuvant therapy. So I thought maybe we could just focus a little bit on the Protege 12 and the BILCAP trials, both of which looked at adjuvant therapy for patients with biliary tract cancer. And interestingly, the Protege 12, which looked at GEM-OX versus observation, really did not show a benefit, whereas a BILCAP trial that looked at capecitabine versus observation, at least in the protocol analysis, did show a significant survival benefit in the treatment group. And capecitabine in the adjuvant setting really has been adopted for many patients with resected biliary tract cancer. So I'm wondering if you could just comment a little bit more about each of those trials. What are your thoughts about the different results, the different treatment designs, patient cohorts, et cetera?
Yeah, absolutely. So I will start by saying over a decade now, gemcitabine combined with the platinum drug, most often cisplatin, GemCis, has really been the standard of care and pillar chemotherapy regimen that we use for advanced disease biliary tract cancers. So case in point to what I'm saying is really capitalizing on what we know in the advanced disease space and testing those regimens in either the neoadjuvant or adjuvant space is exactly what PROTEGE study did. Instead of cisplatin, they used oxaliplatin. So they did GEM-OX versus placebo. And although there was a, clinically difference there in terms of 30 months versus 18 months, it did not reach statistical significance. There's lots of influences and lots of factors that go into p-values in terms of the power of this study, what you expect to see, what actually happened. But as you said, that was a negative trial. Despite that being a negative trial, however, I think given the strength of GemCis based on the ABC02 study, there are many people around the world who still utilize a gemplatinum regimen in the neoadjuvant and adjuvant space, despite that trial being negative. And that's just the honest truth of clinical practice. So after BILCAP came out with basically adjuvant capecitabine versus placebo or best supportive care, this was, again, if you look at from the purest standpoint of a scientific trial, on the intent to treat analysis, the p-value was not less than 0.05. Now, it missed by a little bit, but the clinical difference between the two was very significant. Again, despite a p-value being greater than 0.05. And as you mentioned, the per protocol analysis, which actually only excluded 10 patients in the treatment arm, was significant by a p-value. So based on just the data that we have, the BILCAP trial probably is the strongest and best evidence we have now, and capecitabine, per the ASCO guidelines, adjuvant guidelines, is recommended as the recommended choice for adjuvant chemo with 6 months of capecitabine. But still, people are using gemplatinum, and we actually wrote in the adjuvant guidelines that the gemplatinum regimen is an option as well.
And then I would be remiss if I did not bring up your own trial, Dr. Maitel, which you were a PI on, that involves gallbladder cancer. I was hoping that you could briefly share with this audience what that trial is about, what question it's trying to answer, and how surgeons can get involved to help us realize your accrual goals of that trial.
Absolutely. Thank you. So that trial is EA 2197, or called opt-in, and it's for incidentally diagnosed gallbladder cancer. So in this country, 2/3 of the majority of gallbladder cancers are diagnosed incidentally after a patient undergoes a laparoscopic cholecystectomy for what is otherwise presumed benign biliary stone disease. And then on pathologic review of the specimen, they find an incidental cancer. The standard of care right now would be to do a re-resection where instead of just removing the gallbladder, we also take out part of the liver around the gallbladder bed as well as the lymph nodes in the area, and plus or minus the bile duct based on the margins that were taken off the cystic duct. The recommendation for that re-resection would be for T2, T3 disease, and sometimes for T1B as well in terms of the T stage. We know, however, that many of these patients, particularly T2 and T3, 50 to 60, 70, 80% of them will have some residual microscopic disease at the time of the re-resection. And unfortunately, the recurrence rates and the overall survival rates have a lot of improvement to be done. They're not as good as we want. Many of these patients recur, and the overall survival is limited for these patients. So the trial that we're doing is really looking at the value of doing neoadjuvant therapy prior to the re-resection after diagnosis of a T2 or T3 incidental gallbladder cancer. And the regimen we use, again, pertain to what I was saying in terms of extrapolating from advanced disease space. We are using GemCis as the chemotherapy regimen. So the randomized trial is basically the treatment arm would be getting 3 months of GemCis prior to re-resection, then the re-resection followed by adjuvant GemCis, versus the control arm would be upfront re-resection, which is the standard of care. And also, again, in this setting, the adjuvant therapy is not capecitabine. It's actually adjuvant 6 months of gemcitabine cisplatin. Again, case in point to that, the NCI actually favored using GemCis instead of capecitabine for this study. The surgeons can get very involved because these patients are often diagnosed in the community and then are referred to the academic center, but often the referral goes straight to the hepatobiliary surgeon or surgical oncologist. So the surgeons would see these patients first, and it would be great if we knew about this trial, advocated for the trial, explained to the patients the importance of this trial, and then worked with their medical oncology colleagues at their institution to enroll patients in this study.
I think those are all excellent points. And, this last point about a surgeon involved in the clinical trials is just so critical. And that might provide a nice pivot point for us to move on to our next article, which is indeed entitled Surgeon-Led Clinical Trials in Pancreatic Cancer. And just as you're a national expert in clinical trials for biliary tract cancer, again, we're lucky that Dr. Ahmad here, who's national expert in clinical trials related to pancreatic cancer. So, Syed, in this article by Chawla and Dr. Faroni, they do a really nice job outlining the various trials that have been done in the adjuvant, neoadjuvant setting for pancreatic cancer. And I thought, given all of your expertise, that you might highlight for our listenership really what are the key take-home messages around adjuvant trial data that surgeons should be aware of? And then similarly, in the neoadjuvant setting, what questions have been answered by clinical trials? And are there persistent questions that need to be addressed about the role of neoadjuvant chemotherapy for pancreatic cancer?
If you look at this article, it did a very nice job of kind of walking us through the development and advances with systemic therapy and sequencing of systemic therapy for pancreas cancer. So first thing to really understand is understanding the different local regional staging for pancreas cancer. And, we classify them as resectable, borderline resectable, or locally advanced. So patients with resectable tumors are typically, at most institutions worldwide, treated with a surgery-first approach followed by adjuvant therapy. And adjuvant therapy can be chemotherapy alone or chemotherapy and chemoradiation. And really, for the longest time, the only active drug we had was 5-FU. And that was based on a small study performed in the 70s, the Gastrointestinal Tumor Study Group. And it wasn't until the European Study Group for Pancreas Cancer, SPAC, started doing additional cooperative studies in Europe looking at different chemotherapy. So the first article that's really highlighted is the SPAC-4 study, which was a landmark study that looked at the standard adjuvant regimen, which was gemcitabine, and compared to a newer regimen at that time in the early 2000s, which was gemcitabine and capecitabine, GEM-CAPE. And that SPAC-4 study really did demonstrate the benefit in improving survival with multi-agent chemotherapy. And this study was really GEM-CAPE. Now, concurrent with the development in advances in adjuvant therapy was multi-agent regimens that were being developed for advanced cancers, people with metastatic disease. And in those settings, really, we found the combination of FOLFIRINOX, 5-FU, folinic acid, irinotecan, oxaliplatinum, which is also known by the acronym FOLFIRINOX, improved survival compared to gemcitabine. That was based in patients with advanced stage 4 disease. Also, during the development of FOLFIRINOX was the development of gemcitabine and albumin-bound paclitaxel, which is also known as Abraxane in trade name, and that also demonstrated the benefit above gemcitabine. So the natural question was, do any of these regimens work in the adjuvant setting after surgery? And they were tried, 2 landmark studies. The first was a PERDIS study, which looked at adjuvant FOLFIRINOX. And the second was the APAC study, which looked at adjuvant gemcitabine and albumin-bound paclitaxel. The PERDIS study is a landmark study because it demonstrated improvement in survival with FOLFIRINOX over gemcitabine. And not only did it demonstrate improvement in survival, but the survival that was seen in the PERDIS study was unheard of survival that had never been seen in patients with pancreas cancer. The APAC study with gemcitabine and paclitaxel was unfortunately a negative study, although long-term follow-up has started to show maybe a benefit to the dual agent therapy. Now, the PERDIS study is critiqued a bit because it's very highly selected patients that enrolled in that study, patients after surgery with good performance status, based on a preset CA19-9 tumor marker level. They were the best of the best, and a lot of people will say that that is the reason why the survival is so good and maybe even why there was a survival advantage. But that is now the worldwide standard in the adjuvant setting is FOLFIRINOX. Now, as you know, there's been a big push to using neoadjuvant therapy. We know that neoadjuvant therapy is mostly standard in patients with borderline resectable tumors involving blood vessels, the SMV, the SMA, hepatic artery, to downstage them. So in people with borderline resectable, it's almost standard that we utilize neoadjuvant therapy. But there's also a push to use neoadjuvant therapy in resectable patients for the benefit of testing the biology and making sure that patients actually get what we think is the most important aspect of multimodality therapy, which is a systemic regimen. There have been multiple studies looking at the neoadjuvant versus adjuvant question, which one's better? In this article, both aspects have been highlighted. One is in resectable patients, and 2 is the borderline resectable patients. One of the studies that looked at neoadjuvant therapy in borderline was the Alliance 0215 study, which was led by Matt Katz, the author of the previous article we discussed. I was a co-PI in that study as well, and it looked at whether or not radiation was necessary in the neoadjuvant setting. So it was chemotherapy versus chemo and radiation. And unfortunately, that study closed early based on some pre-specified interim analysis metric. Not enough patients were getting the surgery. But really, if we critically analyze the study, the preset metrics were poorly chosen. And I think this study, although negative, and many people say that it was the nail in the coffin for radiation, that's a misinterpretation of the results. I think it's more a manifestation of trial design rather than the lack of benefit from radiation. Now, you can argue, that there wasn't enough benefit from radiation to have a survival advantage and that radiation had minimal effect on these patients. That argument is ongoing. I think in many centers worldwide, radiation has been eliminated both for resectable patients and borderline resectable, although in many centers it's used very selectively. So that was the Alliance 0215 study in borderline resectable patients. Now, I led the SWOG 1505 study, which really looked at the 2 regimens that I described, FOLFIRINOX and gemcitabine paclitaxel. In a head-to-head fashion, it was a phase 2 pick-the-winner design. And we looked at each arm individually against historical control. And if it met a pre-specified threshold, then those 2 arms would be compared to one another. Unfortunately, neither of these arms met the pre-specified level to be compared head-to-head, but both arms beat the historical control. And so they were both active. So there was no difference in survival between the 2 neoadjuvant perioperative regimens, FOLFIRINOX and gemcitabine paclitaxel. Now, again, this is a complex issue, and the burning question really is, what's better, neoadjuvant or adjuvant? Is it sequencing that makes a difference, or is it getting the therapy? The study led by Cristina Ferroni, who is the co-author of this chapter, is the Alliance 0218 study, which is looking at that question. Basically randomized people to surgery first versus adjuvant therapy, or a short course of chemotherapy followed by surgery and a longer course of chemotherapy. So it's basically an adjuvant versus neoadjuvant question. And that study is ongoing. It's met its accrual halfway. It still needs to get a lot of patients accrued. So I would urge everyone listening to this podcast to consider opening the study. But I want to go back to the 1505 study again, because it highlighted several important points. One of the points it highlighted was that if you look at the sequencing, one of the things that we found was most people were able to get the chemotherapy up front, but only half the people, and sometimes even less than half, were able to get the chemotherapy on the back end after surgery, which is one of the reasons why people advocate for chemotherapy in the resectable setting, to make sure people get the chemotherapy. So people say, what's the most important aspect of the multimodality therapy? Is it surgery? Is it chemotherapy? And if radiation used, is it radiation? The most important aspect, in my opinion, is chemotherapy. And if we can use a sequencing regimen that makes sure people get the chemotherapy, i.e. neoadjuvant therapy, then that makes a lot of sense. So the SWOG 1505 did highlight very nicely how difficult it is to deliver adjuvant therapy after surgery. There have been some other studies that perhaps demonstrate the benefit of neoadjuvant therapy, and that was a PREOPANC study. This was done in the Netherlands, which randomized people to chemoradiation followed by surgery, followed by chemo, versus surgery followed by systemic therapy. And that study was really published twice. Initially, the results were negative, but longer-term results showed that patients did have a better survival with the neoadjuvant study. And now there is a PREOPANC 2 that's ongoing, enrolling patients. I think it's actually finished accruing, but the results are still pending. So there's lots of burning questions in pancreas cancer clinical trial design. The best chemo regimens, the best sequencing, and whether or not radiation needs to be utilized.
Yeah, that was a really fantastic overview of the article and the state of affairs vis-a-vis adjuvant therapy and neoadjuvant therapy for pancreatic cancer. One thing that you touched on, a controversial subject in pancreatic adenocarcinoma, is the role of radiation therapy. So maybe just briefly, can you comment on what is the role? What do the data suggest relative to the benefit of radiation therapy, whether it be in the neoadjuvant setting or the adjuvant setting?
So in the adjuvant setting, it's probably the most controversial topic in pancreas cancer. Should radiation be used? And really, again, the initial trial that demonstrated the benefit of adjuvant therapy was a GITSIC study, and was really adjuvant chemoradiation, although they did get a long course of 5 FU in that study. And that was the standard of care for the longest time until SPAC1, which was a complex trial design. It was a 2x2 factorial design. But the gist of that study was that radiation did not have a benefit in survival. And based upon the SPAC design and trial result, in Europe, radiation was really eliminated. And in America, it continued to be utilized by many centers. And there, again, have been multiple studies that have looked at the radiation question, but there's never been a positive study. So in the adjuvant setting, radiation is used selectively by centers. Most centers in the US, I would say, have gone away from radiation in the adjuvant setting. Now, one can argue that if you look at the recurrence rate of pancreas cancer, a subset of patients, 10 to 20%, recur locally only. And those are the patients that probably benefit from radiation. So moving forward, the question we need to answer is which patients benefit from radiation? If all patients don't benefit, then is there a subset that do benefit? And perhaps we can use things like radiomics or biomarkers or mutational analysis to determine which patients have the propensity to fail locally, and maybe we should save radiation for those patients. We know that pancreas cancer is a systemic disease, and even if you fail locally, you're also going to probably fail systemically, and that's why radiation by itself doesn't improve survival. It may improve recurrence-free, a local recurrence-free survival, but it doesn't improve overall survival. And the second question is really, again, in the borderline resectable patients, where the Align 2215 was trying to answer whether you need radiation in the borderline setting. And again, that trial closed early, but I think that people look at the results of the study cautiously based on trial design rather than results in effective radiation. And I do think there's still centers that utilize radiation in the borderline setting. At University of Cincinnati, we continue to use radiation in the borderline setting. Again, borderline would be vascular involvement of the vein more than 180 degrees or arterial involvement less than 180 degrees. We don't use radiation in the resectable setting.
Well, that was a really robust conversation about pancreatic adenocarcinoma and also biliary tract cancers. I'd like to kind of maybe take a step back and talk about another article, really important topic that touches on all clinical trial work, and that's the topic of diversity, equity, and inclusion. And this article by Keegan, Crown, and Joseph highlights some of the barriers to getting equitable access to clinical trials, and then also highlights some of the potential approaches to overcoming the traditionally poor patient enrollment among patients who have traditionally been underrepresented. So, Dr. Maitel, I was wondering if you could comment on this article, and maybe you could just comment a little bit about how having inclusivity in clinical trials is not only the right thing to do and is important from a health equity point of view, but it's also good science.
I agree with you 100%. This is an extraordinarily important topic, and a topic that I think has been ignored for a long time and has not been emphasized enough. And finally, I think we've realized that we really need to improve the mechanism by which we do these. So I'll comment on a few things. One, if you just look at kind of the need for this, if you just look at Black patients in general, Black patients may have a lower incidence of cancer compared to white counterparts. However, their mortality from cancer is higher. So there is definitely some sort of either there's a biological factor here, or there's an access to care issue here. There's a receipt of care issue here. There's something going on here that we need to really address. And in terms of the clinical trials, when we do clinical trials, we try to come up with answers that will help the general population as a whole. We're testing something, we're testing a new drug, a new therapy, and we want that drug or therapy to basically benefit everyone. We cannot apply the results of these trials to everyone if we don't have a good representation of the population in the clinical trial that generated the data in the first place. So from a scientific standpoint, it makes complete sense, as you alluded to have good representation of our minorities, or just a group of underrepresented minorities as differentiated by socioeconomic class or race, ethnicity, because that is the population that we live in. And as we generate trials and data, we need to generate the data from patients that would be receiving these types of medicines. So that's something just from a scientific standpoint we need to improve upon. So what are some of the barriers? Well, right now, if you look at just some of the data, underrepresented minorities are often less offered clinical trials to be enrolled in. So we need to work on that as physicians, as our clinical trials office, as providers, in terms of equity in offering the trials. Number two, there is often a mistrust between underrepresented minorities and the healthcare system in general. So we need to start breaking down that mistrust and breaking down that wall and figure out where the gaps are, whether it's cultural, whether it's based on historical, whatever it may be, but we need to start breaking down those gaps and improve the trusting relationship that we have as providers at these institutions with our underrepresented minority populations of patients. The next thing is access to clinical trials. So oftentimes our minority patients or underrepresented minority patients will live, 2, 3, 4 hours away from academic institutions that are predominantly running these clinical trials. So getting access to them in terms of barriers of travel and cost and hotel costs and gas money and food money, all of these things we need to start thinking about much more granularly in order to help bringing clinical trials to our patients who don't live close to the center that's actually doing it. And this kind of goes into the general philosophy and the general pattern of how we're doing trials, is we need to start bringing these trials to the community. We need to get creative in how we can enroll patients in the community, how we can work with our community partners. And I will say this is potentially one positive outcome of COVID, is it really opened up the virtual telecommunications, the way we're doing clinics now virtually, we're doing telehealth visits. There are now precedents for where people are actually getting data for clinical trials virtually. Patients are actually getting treated with standard of care type of medicines that are being tested in some sort of order of things in the community, and actually avoiding having to travel 3-4 hours away each week or every 2 weeks to the enrolling institution. That's something we're trying to do with the gallbladder study that you had mentioned previously. Because we're using gemcitabine cisplatin, which is a standard of care chemo, We're actually trying to write an amendment right now, which will go through the NCI, where patients can actually get their chemo in the community. We'll get the data virtually, and then the patients would return to the enrolling institution for their operations. So I think we just really need to change our mindset in terms of how we get patients to trust us, how we get patients to enroll in trials, and how we make them, most importantly, accessible, because that's the only way the data that we generate will be applicable to the entire population as a whole.
Those are excellent points. I thought something else that was interesting as we're up in the article is maybe some of the systemic problems with clinical trial design that were highlighted, and also representation among clinical trial leadership. One point that was brought up in the article was the need to change perhaps some of the clinical trial design relative to the inclusion of patients with chronic conditions or even those with certain language abilities. So I was wondering if you could comment a little bit about when study designs are going through the clinical trials network, how do the leaders kind of purposely ensure that the design of the clinical trial will enhance enrollment amongst traditionally underrepresented patients? And then my second question is, maybe you could just comment briefly on some of the efforts amongst the leadership in the clinical trial networks to increase representation of women and physicians from URM backgrounds in those networks.
Yeah, no, those are great points. Standard in every clinical trial design or protocol, there's always sections in terms of how are you going to ensure enrollment of women, minorities, and children. And, not all of those apply to every single study, particularly children. Some of the studies that we do are predominantly in the adult population, but women, children, and minorities are always addressed. However, the metric required or really desired to kind of quote unquote check the box is relatively low. So I think we need to be a little bit more stringent on that. And also, when you look at clinical trial design, inclusion-exclusion criterion can be actually quite long. And as you mentioned, there may be lots of exclusion criteria that disproportionately affect URM populations. And so we need to really thoughtfully look at each of these things. We have to make sure that we don't put any patients at risk based on whatever trial we're designing, and make sure we do exclude appropriate risk factors that would not be good for a patient to actually have those drugs. So I think that's a lot of work to be done, and really need to really critically look at those types of things. And then on the other side of things as well, as you mentioned, diversifying the leadership, diversifying the face of clinical trials, diversifying the face that patients see when someone approaches them. It could be as simple as having cultural alignment or a trusting face or a trusting voice approaching a patient about a clinical trial, where maybe the study chair may not even be of the same race or same gender or same anything, but as long as the voice and the representation comes from a trusting face, I think that will also help enrollment and trust.
This has been a very enjoyable and informative conversation with both of you. I want to thank Dr. Ahmad and Dr. Maitel, not only for being with us here today for this podcast, but again, for your great work in amassing, truly who's who in surgery and cancer to contribute to this volume of surgical oncology clinics. As we stated at the beginning, there's no higher level of evidence than randomized clinical trials. This is extremely important work for our patients to discover novel therapies that will lead to better outcomes and more equitable outcomes for all of our patients. So I want to congratulate both of you for being leaders in this space and also encouraging the next generation of surgeons to wholeheartedly embrace this difficult but important work. So Shishir, Syed, thank you, and thank your co-authors so much for your contributions to surgical oncology clinics.
Thank you, Tim, for your leadership and giving us this opportunity.
Yeah, thank you, Tim. It was a pleasure doing this, and it was an honor to participate in this. Thank you.
Thank you for joining us for this Surgical Oncology Clinics podcast devoted to clinical trials in surgical oncology. The 4 articles discussed, as well as 10 others, are in the January 2023 issue, Volume 32, Number 1. The series is available for individual print subscription with online access or individual online-only access. Visit www.surgeonc.theclinics.com to subscribe. The series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on Twitter at surgical clinics, and you can subscribe to the podcast through Apple, Google Play, Amazon Music, Spotify, or Stitcher. Thanks for listening.